Steny Hoyer, the majority leader has already been telling members that, look, it is going to pass by huge numbers. And so if there's self-quarantine, no need to actually travel into the United States. And Dr. Birx is now speaking at the White House. Let's hear what she has to say, please.
Increase when you look at Wayne County in Michigan and you look at Cook County in Chicago. So we have integrated all of our information to not only look at where the cases are today, but how they're moving, so we can alert FEMA to where we think the next potential hotspot is. All of the counties that I've mentioned, the hotspots are in urban areas or in the communities that serve that urban area. And I think that's something very important to remember as we move forward. Because of the innovations within our private sector, we continue to have these new platforms added for laboratory testing. And these become critical platforms for states that have very low rates and very low rates needed to test. Why is that important? Some of these machines have wells and plastic plates that, in order to be effective, you have to put on about almost 96 samples. And others are made for 4 samples or 24 samples at a time. So what's critical for us to be able to do is to match the need to the county and state. And that's the role that we can provide advice on, because we get to see across the whole country and where those items are needed most. And so this is allowing us to adapt and adopt really allocation of tests or recommendations to state of what piece of equipment they may need. Of the 550,000 tests, you can do the math, but we're still running somewhere about 14% overall. That means 86% of the people with significant symptoms, because remember, you had to have a fever and symptoms to get tested at this point. So still 86% are negative. These are really important facts for the American people. I'm sure many of you saw the recent report out of the UK about them adjusting completely their needs. This is really quite important. If you remember, that was the report that said there would be 500,000 deaths in the UK and 2.2 million deaths in the United States. They've adjusted that number in the UK to 20,000. So 500,000 to 20,000. We're looking into this in great detail to understand that adjustment. I'm going to say something that's a little bit complicated, but I'm going to try to do it in a way that we can all understand it together. In the model, either you have to have a large group of people who are asymptomatic, who've never presented for any test, in order to have the kind of numbers that were predicted. To get to 60 million people infected, or of 6 million people infected, you have to have a large group of asymptomatics, because in no country to date have we seen an attack rate over 1 in 1,000. So either we're only measuring the tip of the iceberg of the symptomatic cases, and underneath it are a large group of people. So we're working very hard to get that antibody test, because that's a good way to figure out who are all these people under here and do they exist. Or we have the transmission completely wrong. So these are the things we're looking at, because the predictions of the models don't match the reality on the ground in either China, South Korea, or Italy. We are about 5 times the size of Italy. So if we were Italy and you did all those divisions, Italy should have close to 400,000 deaths. They're not close to achieving that. So these are the kinds of things we're trying to understand. Models are models. We're adapting now to the reality. There's enough data now of the real experience with the coronavirus on the ground to really make these predictions much more sound. So when people start talking about 20% of a population getting infected, it's very scary. But we don't have data that matches that based on the experience. And then finally, the situation about ventilators. We were reassured.
So she's talking about ventilators. That was what Andrew Cuomo talked about. Let's go back to it. I want to hear what she has to say about ventilators.
Remaining, and there's still significant over 1,000 or 2,000 ventilators that have not been utilized yet. Please, for the reassurance of people around the world, to wake up this morning and look at people talking about creating DNR situations, do not resuscitate situations for patients. There is no situation in the United States right now that warrants that kind of discussion. You can be thinking about it in a hospital. Certainly many hospitals talk about this on a daily basis. But to say that to the American people, to make the implication that when they need a hospital bed, it's not going to be there, or when they need that ventilator, it's not going to be there. We don't have an evidence of that right now. And it's our job collectively to assure the American people that it's our collective job to make sure that doesn't happen. Right now, you can see these cases are concentrated in highly urban areas. There are other parts of the states that have lots of ventilators in other parts of New York State that don't have any infections right now. So we can be creative, we can meet the need by being responsive. But there's no model right now, no reality on the ground where we can see that 60 to 70% of Americans are going to get infected in the next 8 to 12 weeks. I just want to be clear about that. So we're adapting to the reality on the ground. We're looking at the models of how they can inform, but we also are learning very clearly from South Korea and from Italy and from Spain. Just a final, because I know many of you will look up my numbers. The only people who are over really 1 in 1,000 cases are people that have very small populations like Monaco and Liechtenstein. So you will see a different number coming from when your population is really tiny. One case can put you over 1 to 1,000 or 2 to 1,000. Thank you.
Good. We'll do questions in a moment.
All right, folks. Actually, I thought Dr. Fauci actually spoke a little bit earlier. He actually is now speaking. Now let's go back.
On a couple of media interactions regarding the interventions that we're talking about. And it's important because it's about something that I said yesterday about what we would likely see. Whenever you put the clamps down and shut things down, you do it for 2 reasons. You do it to prevent the further spread, as we call mitigation, but you also do it to buy yourself time to get better prepared for what might be a rebound. It may be a rebound that we get things really under control, and then you pull back, which ultimately we're going to have to do. Everybody in the world is going to have to do that. You're either going to get a rebound, or it might cycle into the next season. So what are we going to do to prepare ourselves for that? One of the most important things is one that I mentioned several times from this podium, and that is to clarify a bit about the timeline for vaccines, and would that have any real impact on what we would call a rebound or what we would call a cycling in the season. Certainly, for sure, a vaccine is not going to help us now, next month, the month after. But as I mentioned to you, we went into a phase 1 trial, and I keep referring to one vaccine. There's more than one. There's a couple of handfuls of vaccines at different stages of development, but they're all following the same course. And the course is you first go into a phase 1 trial to see if it's safe, and you have very few people, 45 people within a certain age group, all healthy, none at really any great risk of getting infected. And the reason you do that, because you want to make sure that it's safe. Then the next thing you do, and that takes about 3 months, easily, maybe more. So that's going to bring us into the beginning or middle of the summer. Then you go to a phase 2 trial, or what we say 2-3, which means we're going to put a lot of people in there. Now, we hope that there aren't a lot of people getting infected, but it is likely there will be somewhere in the world where that's going on. So it's likely that we will get what's called an efficacy signal, and we will know whether or not it actually works. If, in fact, it does, we hope to rush it to be able to have some impact on recycling in the next season. And like I said, that could be a year to a year and a half. I'm not changing any of the dates that I mentioned. But one of the things that we are going to do that you need to understand that has been a stumbling block for previous development of vaccines, and that is even before you know something works, at risk, you have to start producing it. Because once you know it works, you can't say, great, it works. Now, give me another 6 months to produce it. So we're working with a variety of companies to take that risk. We didn't take it with Zika. That's why, we have a nice Zika vaccine, but we don't have enough to do it because there's no Zika around. Same with SARS. So that's one of the things we're really going to push on, is to be able to have it ready if, in fact, it works. Now, the issue of safety, something that I want to make sure the American public understand. It's not only safety when you inject somebody and they get maybe an idiosyncratic reaction, they get a little allergic reaction, they get pain. There's safety associated. Does the vaccine make you worse? And there are diseases in which you vaccinate someone, they get infected with what you're trying to protect them with, and you actually enhance the infection. You can get a good feel for that in animal models. So that's going to be interspersed at the same time that we're testing. We're going to try and make sure we don't have enhancement. So the worst possible thing you could do is vaccinate somebody to prevent infection and actually make them worse. Next, and finally, with regard, I'll get you to your question. Finally, with regard to therapies. I mean, we keep getting asked about therapies. There's a whole menu of therapies that are going into clinical trial. As I've told you all, and I'll repeat it again, the best way to get the best drug as quickly as possible is to do a randomized controlled trial so that you know, is it safe and is it effective? If it's not effective, get it off the board and go to the next thing. If it is effective, get it out to the people that need it. So you're going to be hearing over the next month or more about different drugs that are going to go into these randomized controlled trials. And I feel confident knowing about what this virus is and what we can do with it, that we will have some sort of therapy that give at least a partial, if not a very good protection in preventing progression of disease. And we'll be back here talking about that a lot, I'm sure. Thank you.
Tony, you can take a question. Go ahead.
If I could just get back to what you're saying about this idea of risk in drug manufacture, are you saying that at some point in the phase 2 trials, that if you're seeing some form of efficacy, that you may try to convince a laboratory to spool up production at that point so that there's a reservoir?
Even before. When I go into phase 2, I'm going to find somebody that's going to make it. Well, partially the federal government, I think in some respects to de-risk it, but also investments by the companies. A lot of companies are not shy now about doing that. Usually when you do that at risk, John, you got to give some backup for them. And we've done that. We've put hundreds of millions of dollars into companies to try and make vaccines. I wouldn't hesitate to do that for a moment now.
Have you ever had a conversation about that? On the county issue, let's talk about having low risk, medium risk, and high risk counties. Or for Dr. Burks. But there's no domestic travel restrictions. What's to prevent somebody from a high-risk county going to a low-risk county? Don't you risk creating a patchwork system, allowing more cases to slip through the cracks and the virus to spread in other areas of the country?
I think this is a very important concept, and it's why we've really worked on messaging to the American people about these 15 days to stop the spread. Because part of this will be the need to have highly responsible behavior between counties. And I think the American people can understand that they will understand where the virus is because we'll have the testing data and where it isn't, and make sure that they're taking appropriate precautions as they move in and out of spaces. I think this will be critical for our future as we work together to really understand where the virus is and where it isn't in real time.
Dr. Burks, let me just follow up on sort of your modeling. Everyone's talking about this Neil Ferguson study out of Imperial and how the modeling's changed. You last week said, or it was on Monday, that you talked about a serology test, something promising coming out of Singapore. Where are we on a serology test? The president said very quickly. And then is that what you need to do, some sort of community survey so you can get to some of these X and Z's so you can figure this all out?
So we're talking to CDC right now. They are extraordinary in outbreaks and contact tracing. So they are going to be the workforce behind any new strategy that looks at counties that need to completely move into containment and surveillance and contact tracing. But part of what they're looking at now is where are these antibody assays. To be clear, there is antibody assays available right now, but they're by ELISA. And what we're trying to do is not just do ELISAs, because they can use that now, but to be able to have point-of-care rapid diagnostics like we have with HIV, where you just get a drop of blood, you put it on a little cassette, and it tells you if you're positive or negative. So that's what companies are working on. Yes, correct. That's the IgG to measure. Now remember, that's not going to be helpful in diagnosis. That's going to be helpful for us to know how many asymptomatic cases there are that or were.
How close are we to figuring out what the asymptomatic rates are? Because that seems to be the big question here.
It is a big question.
Iceberg.
It is a very big question. And so we have people, the FDA is working on that around the clock. They do have applications that are coming in. We put out a call for applications. I've been talking about it from this podium. If you haven't.
I want you to like, share, and subscribe to our YouTube channel, youtube.com/Roland S. Martin. And don't forget to turn on your notifications.